Bom dia, nós vamos dar início então ao nosso Grand Round internacional. Hoje temos, aproveitando a vinda do professor convidado, que vai nos brindar com uma palestra bastante interessante. Eu vou passar para o professor Rogério Xavier para fazer a introdução do nosso convidado. Professor Rogério.
Bom dia a todos. Dr. Sidney Braman, Rhode Island, na Universidade. A iniciativa no Brasil, essa é a terceira vez. Nós já nos encontramos em São Paulo, em Salvador, e para o congresso da nossa Sociedade Brasileira de Psicologia. Foi sempre assim, depois nos encontramos no Quer. Ele é membro da Pulmonary da presidente da escola. Nessa condição, eu veio agora a Florianópolis, essa semana, sobre a asma, a DPUC trabalhando. Então, como já conhecido, eu convidei para vir a Porto Alegre, que aceitou, então, por essa razão, a Braman University é uma das quatro universidades do leste americano, no Harvard, no Princeton e a outra no Yale. São as quatro universidades chamadas Ivy League, Liga afim. Que eu saiba dos nossos colegas, quem esteve lá, do nosso escritor, o FCCP. Eu já estive fazendo uma visita rápida, vontade de voltar de novo. Era muito bom. Eu tenho mais algumas poucas coisas do Dr. Sidney. Ele vem de uma família música, também toca saxofone, toca piano, e também pertence a uma associação interessada em antropologia. Ele recentemente mudou-se para uma casa muito bonita que eu visitei, numa arte toda de concreto e vidro. Então tinha algumas peças antigas dos móveis da família. Ele doou para o Evento Fine Art de Boston. Quem lá queira visitar Boston, colocação dos congressos, deixa está muito interessante mostrar a história da vivência americana, com tudo, vestuário, móveis. Você tem poder compartilhar ideias com uma pessoa que tem vários interesses, que aqui, na lembrança dos nossos móveis, uma profissão. Muito bem. Então, eu vou pedir para
Professor Rivera, Professor Xavier, thank you for this kind introduction and the kind invitation to speak here today. As an American, I come here speaking English, and for this I apologize. I cannot deliver my talk in your language, but as I said to some of the students and residents earlier, this is good practice for you to listen. As you go to international meetings, the standard will be for you to make your presentations in English, and certainly hearing English today, I think, will be a good benefit to you. Professor Xavier introduced me and as a very good friend, colleague, and I am indeed pleased to be here. When I received the invitation, I asked him, what should I say to this group? He knew of my interest in COPD and also the global impact of this disease, and asked me to comment on 2 questions that I plan to do today in my speech. First, about COPD. Can we do anything to improve the quality of life of these poor individuals who are suffering from such a devastating disease? Second, can we improve the mortality rates, which I will show you in a moment, are climbing? In fact, in the last part of the 1900s, in last century, the World Health Organization became quite alarmed, realizing that mortality from this disease was increasing. And they proposed to do a study looking into the future. What will happen with this disease, COPD? And this is what they found. A dramatic increase in mortality projected for COPD long into the 21st century. Very alarming figures. Now, what has happened is that the major diseases of ischemic heart disease and cardiovascular diseases are really not projected to show any change. But look here, COPD, which in the 1990s was the 6th leading cause of death, will climb to the 3rd leading cause of death behind ischemic heart disease and stroke. So we have a big challenge ahead for us. Now, I mentioned the word COPD to this group, and all of you are familiar with the term chronic obstructive pulmonary disease. Physicians, clinicians, healthcare providers, nurses are now becoming more and more familiar with this disease. But the World Health Organization, through its initiative called the Global Initiative of Obstructive Lung Disease, GOLD, was curious. Does anyone else know about this condition, COPD? And they conducted a survey. And this was a worldwide survey. I'm going to now show you the results of the survey in Brazil, which will surprise you. If you notice, when the man on the street was asked, do you know what COPD is? And we look at the results from Brazil, China, Germany, USA, look at the number of people in Brazil who even heard of the word COPD. Then the surveyors went further, and they said, you know, a disease that affects the lungs. Have you ever heard? Do you know what COPD stands for? And of course, more people said yes, but still, look at the number of people in this country who even when prompted, knew what COPD was. So we have an enormous challenge. We clinicians, we physicians have a big challenge. The world out beyond this hospital doesn't even know what this disease is, and part of our work is going to be to educate the populace. This becomes important when it comes for government funding of projects, research for COPD. So I think that we have a long way to go. Now, let's back up, and for some of the students and others in the audience, what I thought I might do is discuss the latest definition of COPD. When many of us went to medical school, we learned that COPD was a disease of emphysema and chronic bronchitis. It still is. We know that it is a disease that causes an obstruction of the flow in the airways due to these 2 conditions. Let me now show you the current modern definition of COPD, the most commonly used definition from the Thoracic Society in the US and in Europe. the European Respiratory. They state that COPD is a preventable and treatable disease state. Very curious. Why would they start a description of a disease telling us first we could treat it and, oh, by the way, we can prevent it? Because, as the definition goes on to say, these are important things that in the past were not appreciated. Airflow limitation that's not fully reversible. Do we treat a disease where airflow limitation is fully reversible in many patients? Asthma. So this is a disease different from asthma. The airflow limitation is progressive and associated with an abnormal inflammatory response of the lungs. I met with some students and residents just an hour ago, and we talked about inflammation and how important it is for many diseases in the body. And it was only recently, within the last few years, that it was understood that COPD also is a disease of inflammation in the lungs, and we are now learning that this inflammation spills into the blood and perhaps has important systemic consequences. So it is an inflammatory response of the lungs to noxious particles and gases, most important, cigarette smoking. And COPD affects the lungs and has significant systemic consequences. This is the new definition of COPD. In years past, there was a very nihilistic approach to this disease, meaning doctors couldn't do very much, there weren't many medications, there wasn't a lot to do, and there was a general feeling that the patient gave the disease to themselves. I think nowadays the thinking of COPD is much different, much more positive, and we recognize that if we can get a handle, we can stop the smoking, stop the disease, and indeed we have better drugs to treat the disease. So what is the inflammation of COPD? Here is a scheme that was produced for the New England Journal just recently, updated, 2003, and this scheme is outdated, as I will show you in a moment. We recognize that cigarettes activate in our airways and alveoli macrophages. Macrophages are the good cells that sit in our lungs and are waiting for viral or bacterial infections or perhaps dust to engulf and get rid of the invading agent. But the cigarette smoke causes many, many more macrophages than ordinarily are there. And these begin to be activated, which means they begin to release chemicals, cytokines, chemokines, which are chemicals that bring more cells in, growth factors. These are things that are going to be causing damage to the lungs. They also release neutrophils. They cause an increase in the number of neutrophils in the lung. These neutrophils, we know, contain certain proteases, certain enzymes. These proteases can damage the lung and cause inflammation and destruction, and we get emphysema, as well as a neutrophilic bronchitis. Well, this is the scheme just a few years ago. We now know that this disease, the inflammation, is much, much more complicated, much more complex. As a matter of fact, in a study recently done in 2004, Professor Haag from Canada showed us that if we look at stages of COPD from very mild disease, so-called stage 0 from the GOLD guidelines, all the way up to stage 4, that the inflammatory cells are shown to increase. They increase as the disease progresses. And surprising, not only neutrophils and macrophages were seen in these biopsied lungs, but look at the inflammatory cells. Yes, neutrophils. Yes, macrophages. Also, eosinophils increased. lymphocytes, the CD4 cells, CD8 cells, and even antibody-producing B cells. So we now understand that the inflammation of COPD, highly complicated, many cells play a role, and these cells release the mediators that cause the damage in the lungs. So the schema is that we have insult causing inflammation. This inflammation causes a bronchitis, in the smaller airways. This inflammation causes destruction of the lung in the lung parenchyma, and both lead to airflow obstruction. While never mentioned in any of the statements, the definition, the guidelines that come, we just heard that COPD is a disease of chronic bronchitis and emphysema, although the words are no longer used in the definitions. Here's what it looks like. This small airway inflammation. Here you see an airway in the center, and it is surrounded by these black dots, which are lymphocytes. This is an intense inflammation around this airway. Here's an alveolar septa here, here's an alveolus here, and over here is the inflammation around this airway right here. Inflammatory bronchiolitis. Small airways are inflamed. And here, of course, is what emphysema is looking like. Holes in the lung. This is all caused by destruction from these proteases, causing the lungs actually to be destroyed. One of the tragedies of COPD is that it is a very under-recognized disease. I'm going to talk a bit more about this. The problem is that we have the right tool. This right tool is spirometry, and it has been first described in the 1840s by Hutchison. This is a picture of him doing spirometry, and yet now more than 100 and some years later, still this simple non-invasive tool is not being used adequately to detect disease. Doctors just don't think of sending patients. Yet, it has greater specificity and sensitivity as a test for COPD than the electrocardiogram has for coronary disease, and yet many patients will go to their doctor for their yearly physical. Heavy smokers will get an electrocardiogram, never will they get spirometry to diagnose their COPD. This, as many of you know, is what the spirogram looks like. The patient takes a deep breath in and blows out hard and fast, and this is what the normal curve looks like. If your airways are blocked, obstructed, the airflow is limited as it exhales out, and we can make certain measurements like the amount of air that is exhaled in 1 second, the forced expiratory volume in 1 second, and we can see here that less air comes out, and this is a way of detecting COPD and actually measuring the severity by this FEV1 test. And this is the severity that has been proposed. It is a stratification, both proposed by the Thoracic Societies, European and American, and by the Gold Group. Staging goes from 1 to 4. The worse you are, the higher the stage. And this is all based, as you see here, on the FEV1, the forced expiratory volume in 1 second. In the older classifications, there used to be a stage 0, and this was removed. But this is probably a good thought, that we have a stage of disease where there is no abnormality in lung function, but we know because the patient is a smoker, they are at risk of getting this disease. Here's what happens if you are a smoker and you are susceptible to the disease. I remind you that all of us, normals, non-smokers, will have a decline in lung function over time. This is age, here's lung function. So as you're sitting here now, your lungs are deteriorating over time. It doesn't happen so quickly, but it happens over decades. Why does this happen? It happens because it's a normal body occurrence that the elasticity of our tissues become less and less, and the lung elasticity becomes less and less, like it does when you have lung destruction from emphysema. Now, does it really surprise you to learn that your lung function declines because of reduced elasticity? Think of the skin as we age. Think of the aorta as it uncoils as we age. This is the normal aging process. Most smokers will have an advanced decline in FEV1, but not that great. It is the susceptible smoker, perhaps 20+% of the population, that smokes and is susceptible, and look what happens. Their lung function declines rapidly. They become short of breath, they become oxygen dependent, homebound, and eventually may die of their disease. This is the patient who develops COPD. Now, there's a new story for the Marlboro Man. Many of you have seen this advertisement for smoking. The Marlboro cigarettes come from the US. Unfortunately, many of these Marlboro men, these tough cowboy types, they've got emphysema. But the good news is that studies have shown that if the patient can quit smoking, as we see here at age 45 and either at a later age of 65, the slope slows down, that you do not have this rapid decline. So the good news for our patients with COPD is if we can get them to stop smoking, their lung function decline will slow down and they will live to a greater age. This is an important point when we talk to patients about smoking cessation. Yes, we can stop the decline of your disease. Important to remind them that this number will never go back up to normal, but the slope will slow down even at a higher age. So, I think this is a challenge for us. A, to stop patients smoking altogether. In our country, we're now down to under 20% of the adult population. I would hope that Brazil can get to that soon. I know that the number is a bit higher in men and women, better in women than men. But this is something that we clinicians must target. We must push for legislation to prevent smoking in the population. We know that brief strategies will help patients quit smoking. We must ask them about it. Systematic identity, users at every visit. I have had many patients who I've gotten to stop smoking. I stop asking the question. 1 or 2 years later, I ask again, and yes, they're smoking again. This has got to be a constant question. To advise them about smoking use, I'll show you that it helps to assess their willingness to quit, to assist in the patient's quitting, and certainly arrange a follow-up to make sure that this happens. These are the 5 A's of quitting smoking. Counseling delivered by physicians and other health professionals significantly increase quit rates over self-initiated strategies. Even a brief 3-minute period with the patient can improve quit rates as much as 5 to 10%. Just asking a patient, admonishing a patient, pleading with the patient, stop smoking can help. Pharmacotherapy is recommended when counseling is not sufficient to help. Now, what works? I mentioned counseling, both individual and group counseling, and I know there has been a program set up at this hospital which has been very effective in helping patients with their counseling. Pharmacotherapy is important, and I'll discuss the nicotine replacement, the antidepressant bupropion, and the latest therapy we have, varenicline. And certainly there are those who purport to have hypnosis, acupuncture, yoga, whatever works, make it happen. Here are some of the pharmacotherapies. We know that nicotine replacement therapy, there are some precautions in patients with serious arrhythmias, so maybe some worsening of angina pectoris. In patients experiencing recent myocardial infarction, it probably is worthwhile waiting. The side effects are just an inconvenience, which just depends on the formulation, maybe a little skin irritation from the patch, for example. The antidepressant has side effects of insomnia, dry mouth, nervousness, rarely rash, and seizures. There is a warning on this drug. that suggest that you've got to be careful evaluating for depression, suicidal ideation and attempts, and even completed suicide has been found. This is true, obviously, of a number of the antidepressants that we use. Similarly, varenicline, nausea, insomnia, abnormal dreams. There is also, in our country, a warning, so-called black box warning, for depression and suicidal ideation for this drug also. So, do these measures work? And the answer is definitely yes. We see here that the relative odds of this pharmacotherapy improving outcomes favors treatment for each one of these: the bupropion, the nicotine replacement, whether it be a gum, inhaler, nasal spray, patches, or the varenicline. Each one is effective. Here we'll show a meta-analysis of a number of studies, and you can see here the percent of abstinence rates here at 6 months, and the sad number is that each of these numbers, the most likely 6 month is around, as you see down here, 30.5% with the nasal and the bupropion in these studies. So we are really having a big challenge. Even with the best of pharmacotherapy, the quit rates are still relatively low with these agents. Now, with varenicline use, we must consider the combination therapy with sustained releasing bupropion. They are different therapeutic targets. There's no important drug interactions. They may provide an option for treatment in smokers who've had relapses. Combination therapy with nicotine replacement therapy, there is the problem of some nausea side effect, and it may increase when both drugs are used. It's usually not recommended to do both together, but many have done so successfully. You certainly would not prescribe with individuals taking SSRI because of the suicide problem. Here is the results for varenicline. We now know that here is the 24-week, and here to the right is the 1 year, the 52-week, and you can see here that at best with varenicline, using it for 24 weeks totally, that the 43.6% at 1 year is the best we're going to get. So what this all says is that every measure we use, the quit rates are still less than half, sadly enough. Now, one of the things that often I tell my patients who tell me, I've tried, the answer is try again. Because you see here the number of attempts of successful smokers here, the former smokers here, the number of attempts can be 2 or 3, 4 or more attempts until they finally stop. So the message, keep trying to stop. Most patients don't do it the first time or even the second time. You have to keep trying over and over again to stop. What about the pharmacologic options for COPD? Well, they are in two categories, as you see here: bronchodilators and anti-inflammatory. We have the short-acting agents like salbutamol. We have the long-acting agents like the beta agonists and anticholinergics like tiotropium. And we have anti-inflammatory effects of the steroids like fluticasone, budesonide, and in combination with the long-acting beta agonist. These are the available medications. Perhaps in the future we'll have something that I won't have time to talk about, a new class of agents, the so-called phosphodiesterase 4 inhibitors. We're now using PDE5 inhibitors for different reasons. There's also an isoenzyme PDE4 which may have anti-inflammatory effects in COPD. So, how do we long-term manage patients with COPD? Well, we see the step-up therapy, and depending upon the stage of disease, mild, moderate, severe, or very severe, the medication increase from as-needed therapy to regular bronchodilators to adding inhaled corticosteroids, especially if there is previous exacerbations of bronchitis, and low FEV1, less than 50% predicted. And then we have measures such as long-term oxygen use, surgical procedures. Everyone, as you see, gets vaccination with influenza, and I think I would at least recommend pneumococcal vaccine in these patients, although that's been somewhat controversial. So this is the scheme. You start simple, PRN, you continue to add as the patients worsen and get further and further stage or more symptoms. So now I turn with this background to the question that was addressed to me. We see that we have various measures. We have preventive measures. We have pharmacotherapy measures. I mentioned other measures like oxygen and surgery. Do they help? Does it matter? Can we affect outcomes such as quality of life and mortality? Well, the answer is yes to both questions. But I remind you that COPD is not a disease like pneumonia, which you're sick for a few days, or inflammatory arthritis, which you may be sick for several months. That this is a disease that takes years to get, decades to develop, to severity. So when we ask about, can we affect mortality, can we affect quality of life, we're dealing with the disease of so many decades that these are very, very difficult questions, and it really depends upon what stage of life you're evaluating. Let me give you some examples. COPD, as I said, is a disease that develops over decades. Do we really have the tools through these stages? Many teenagers have a cigarette addiction before their 18th birthday. Yet, I showed you a slide where patients with stage 0, before they even get the disease, have intense inflammation in the lungs. COPD is beginning in this young smoking girl in her teenage years, in her 20s. She doesn't know it. We can't test it. We can't measure it, but it's occurring. So when we think of outcomes, we need to be thinking way back even to the earlier stages of disease. Then she develops into a woman in her midlife. She begins to develop changes of COPD. But this disease affects the smaller bronchial tubes. This disease is absolutely asymptomatic because these small bronchial tubes don't really contribute much to the resistance of breathing, and hence even some of the measurements we make may be minimally affected, if at all. So it's a silent disease in midlife. She then gets to a more mature age. Here, if we were to measure, we would find that she has COPD. But does she admit to it? No. She ignores the symptoms. She says, well, I'm just getting a little older. She stops walking the dog in the morning. She stops taking the stairs. She'll look for the elevator. And she will certainly not complain about her COPD. Can we affect her outcomes? No. Spirometry is very underutilized. And so often we are not seeing the COPD patient until this age here, when she has, in addition to the white hair, advanced disease. She has severe disease, and more and more patients are diagnosed at this late stage. So when we contemplate the quality of life issues, when we contemplate mortality, I think that we are really focusing in on often the disease at a very later stage when it presents, as opposed to this earlier stage. Can we affect quality of life? Absolutely yes. Here, for example, is a score of shortness of breath. Here is a drug commonly used, tiotropium, a long-acting anticholinergic. Here is the placebo. Can we affect this over the year? Absolutely yes. Shortness of breath scores much improved throughout the entire year taking this drug. Can we affect other symptoms? Here is a combination of two drugs, a formoterol and inhaled corticosteroid, and indeed, look what happens here. We can reduce symptoms significantly: breathlessness, cough, and sputum. And this is a study, 12-month, showing that we can make people better, improve their quality of life, their symptoms. And indeed, we even have very carefully calibrated scoring systems, questionnaires to test carefully whether we can affect the quality of life. Here, for example, is the questionnaire that we use called the St. George's questionnaire, which not only looks at the pulmonary symptoms that I just mentioned, but also looks at the disturbance of other physical activities caused by the shortness of breath, the psychosocial effects of the disease, and the overall health status. And indeed, we can measure these parameters in patients like we do here, showing that in this case, again, a long-acting anticholinergic, looking at placebo, looking at the quality of life on the drug. Anything that goes down is good, is positive. Higher score is worse. Lower score better. And look at the improvement that we have. Again, after 1 year, we can make an impact with these drugs on patients' symptoms and, as you see here, on their quality of life scores, their total quality of life. Rehabilitation. We can measure how far patients walk, various tests that we can use, a medical research scale of how short of breath are you, and indeed by using pulmonary rehabilitation, we can improve exercise tolerance as well as quality of life scores, as you see here in a 24-week study using an exercise program. Can we affect symptoms? Yes. Quality of life? Yes. Medications, rehabilitation can improve these parameters. Here, for example, is another exercise capacity control. One of the things that clearly worsens the patient with COPD and his quality of life is something we call exacerbation. An exacerbation is defined as an acute sudden change in shortness of breath, cough, sputum, sufficient to warrant a change of therapy. It is very, very common. Here is a 12-month study I quote. 77% of patients seen in a primary care practice report having at least one exacerbation of COPD. These are COPD patients. Common condition. Now, what has been shown several times is that these exacerbations, these flare-ups, these episodes of acute bronchitis worsen quality of life and lead to a more rapid decline of lung function. They negatively impact on quality of life. Each one of these parameters shows a higher quality of life score when these patients here are the high exacerbators here. Symptoms, activities, impacts, psychology, all worsened with more exacerbations. And indeed, look at the effect of exacerbations on survival. Here's a survival curve over 60 months, 5 years. No exacerbations, 1 or 2 exacerbations, 3 or more exacerbations, more effect on survival. Lower survival with exacerbations. Can we improve this exacerbation rate? The answer is yes. Pharmacotherapy can improve exacerbation rate. Here we have, for another example, with the ipratropium again. The tiotropium again. This was compared to the shorter acting. We can see fewer exacerbations and even fewer hospitalizations with the use of the tiotropium. And combination therapy, for example, with salmeterol and fluticasone, the inhaled corticosteroid, long-acting beta agonist. Again, reduction here in this study, a 30% reduction in this Ferguson study over a year, the annual rate of exacerbations. Can we affect exacerbation rates? Absolutely yes, with the pharmacotherapy that we have. Now, the tough one. Can we really affect mortality in this disease? The answer again is yes, limited data. Let's look and see. Well, first, we know that mortality is very much related to FEV1 change, the lung function change. Here is a study done years ago, and this has been repeated, showing that the worse your lung function down here, the higher the mortality rate. Look at this mortality rate here. Percent surviving is only 60% if your lung function is poor, under 30%. It's much better if your lung function is less impaired. So we know poor lung function, high mortality. Well, what do these drugs do to lung function? Well, Unfortunately, drugs like the tiotropium, the long-acting anticholinergic, in this trial done over 4 years, shows absolutely no change in the slope taking it versus placebo. You do not affect lung function over time with a long-acting anticholinergic. And this translates into no effect at all on mortality with this drug in the same trial, 4-year trial. What about the combination of inhaled corticosteroid long-acting beta agonist, the other common medication for COPD? Once again, there is a minimal effect. You can see here placebo on the top, the drug on the bottom. Maybe we're talking 14 cc's a year, 14 mLs a year, tiny amounts. And did it affect mortality? The answer is no. Look at placebo, look at drug, and the p-value here did not reach statistical significance. So we cannot say that any drug, any medication for COPD affects mortality. There's an absolute reduction of only about 2%. But let's go back to that smoking cessation data we showed before. We know that when followed for 11 years, those that continuously smoked down here had a slippery slope of lower and lower lung function, FEV1, whereas those that sustained quitting had a much improved outcome with respect to lung function. Now, we also found the mortality rate was unusually high in this group of continuous smokers seen right here. Deaths per 100,000, quitters, the intermittent quitters, those that started and stopped, start, stop, and these are the ones that continue to smoke, a higher, almost twice the mortality rate. Can we affect mortality in COPD? Yes, with smoking cessation, as the study showed here. Other therapies. We've known for decades that oxygen, if your oxygen level is low during the daytime, that putting you on oxygen at least 16 hours a day, here again is cumulative survival. Here is the time, again, over several years, and we see that either in 2 trials, the U.S. trial, the so-called nocturnal trial, and the research counted trial, here's a control over here, that mortality, the survival is better if you can take continuous oxygen. What about surgical management? Well, there are 3 approaches to surgery: bolectomy, lung volume reduction surgery, and lung transplantation. Bolectomy is a surgery for localized disease, which a large bulla assumes a great proportion of one hemithorax. Lung volume reduction surgery, I will discuss in a second, and lung transplantation for more severe disease, hypercarbonic respiratory failure, pulmonary hypertension, very low FEV1. The mortality in that is about 50% overall in 5 years. So it obviously will save a life, but again, outcomes are somewhat limited by the fact that mortality rate is so high at the end of 5 years, improving over the last decade or 2. What is lung volume reduction surgery? Well, it's actually surgically removing parts of the lung that have emphysema. As you can see here from this right-hand panel, where the resected sections of the lung are. Here's what it does. On the left-hand side is the person before the surgery. On the right-hand side is the patient after surgery. You can see the marked overinflated lungs, the flattened diaphragms, which are improved after the surgery. So, how does it work? Well, we think that in some way there's improvement of elastic recoil. These lungs are so stretched out that if we can only reduce that volume, especially taking the most diseased parts away, that'll help. We improve the ventilation-perfusion mismatch when expanding compressed areas of the lung. It unflattens the diaphragm and makes it much better in terms of its action, and we can improve maybe the right ventricular function. Does it work? Well, this shows that in the national trial in the U.S., the NET trial, that surgery had a higher mortality. in this subgroup of patients, where the lung function was very severely reduced at less than 20%, and there was more homogeneous emphysema, and the lung diffusion was also much worse. But good news from the trial is that there was an improvement in survival in patients in a specific group. Here's the surgical therapy survival, higher mortality in the medical therapy group. The survival benefit was seen only in patients who had predominantly upper lobe emphysema and low exercise capacity. There is about a 5% mortality from surgery alone. I personally have had experience with a number of these patients, and after sometimes a prolonged hospitalization, ventilator dependency, these are not easy patients to do surgery on. So, what was thought is that why can't we do this endoscopically as opposed to surgically, either with surgical sternal splitting or with the thoracoscopic approach? Let's use instead the bronchoscope. And we were very fortunate in this center here, in this city here, to have this technique, this procedure available to your patients. There are three possible ways. One is the bronchial occlusion devices, or valves, that I will show you. We can promote focal atelectasis by actually using solutions that induce fibrosis in the airway. And then there's a rare, less developed way of actually putting fenestrations in the airway itself to improve expiratory flow rate from the hyperinflated areas. This is what a valve looks like, and it's in place, and you see that you have, you just need to get rid of that, in place, and this is something that is done frequently here in this institution. Here's what the valve looks like here when in the airway, hopefully deflating the airway. So the thoughts are, like lung volume reduction surgery, this endoscopic lung volume reduction will do the same thing. Reduce the volume in the chest, improve the ventilation perfusion, improve the volumes in the chest by having a better function of the diaphragm. Well, this has recently been questioned, and it's been questioned by your group right here. Dr. De Oliveira and his colleagues showed by using endoscopic techniques that when you look at the volumes in the chest, the traditional things that would improve, such as the lung capacity, the FEV1, if you look here in the p-value, there is no change, although the patients did improve in certain domains of the quality of life. Why this is occurring, he does not know yet, and the group does not know yet. He indeed questions whether lung volume reduction is really the mechanism, and really calls this procedure the transbronchoscopic pulmonary emphysema treatment, because perhaps volume reduction is not really what's occurring. I think this is a new and exciting world for the COPD patient to improve outcomes, as we talked about. So let me summarize. COPD is a disease characterized by inflammation, and we need to think of it as one of the major inflammatory diseases. Pharmacologic intervention and pulmonary rehabilitation can improve symptoms and quality of life. So the answer to my question is yes, quality of life is clearly from the pharmacologic treatment that I mentioned, the long-acting bronchodilators and inhaled corticosteroids. This intervention can help, rehabilitation can help improve your patients' lives. What about the brass ring, mortality? Well, certainly they can be improved by smoking cessation, they can be improved by certain surgical techniques, and can be improved by oxygen, but that's as far as we go now. I don't think pharmacology can be helpful. So in summary, I thank you so much for this invitation. I appreciate the opportunity to speak before you, and I'll turn the program back to Dr. Shah.
O Dr. Sérgio me informa que, embora o tempo esteja adiantado, alguma pergunta ainda poderia ser feita, se vocês desejarem. Então, nós vamos agradecer mais uma vez. Obrigado.